Time now for this week's Health Matters. Paul Critz with you, along with PA Lynn Szabo. And Lynn, why are we talking about Ozempic again?
Because I've been watching Ozempic-like drugs, and I'm starting to hear things that are brightening my view of them. And I thought it was worth talking about. Super skeptical the last time we talked about it about a year ago. But now I might be the go-to person at UHS to get put on these drugs.
Wow, okay. Well,
it seems like that's what I have about 40 or 50 people on them now.
So refresh us. I mean, what is Ozempic? How does it work? What is it used for primarily?
Okay. So there's a lot of brand names, and I'm going to use a lot of brand names. That's not okay in medicine. You're supposed to use the generics, but they're unpronounceable and people don't recognize them. So I'm talking about drugs like Ozempic, Wegovy, Zepbound, Mounjaro, and these are in a category that's called GLP-1 medications.
Okay.
And they're injectable drugs, but just subcutaneous, so not really it's a kind of injection you could do yourself.
Yeah, you don't have to get in a vein or anything.
No, it's not any deeper than, say, if you poked your finger to get a blood sugar. Okay. And these medications do a lot of stuff, but one of the biggest things actually is they slow the GI rate of transport, so gastrointestinal rate of transport through the body. So stuff kind of sits in the stomach and slowly goes through the intestine. And that's what was thought kind of the main way they worked, just to slow things down so people didn't get a big dump of sugar in their bloodstream after they ate. And, they would feel kind of full.
Longer, right? Yeah.
And not really go for snacks and stuff like that. But it also is doing a lot of other cool things. I should also say I don't have any financial connection to these drugs. Way too bad. Because they are expensive. And I got my information from a lot of places, but the most succinct was a Healthline article, which is called 5 Ways Ozempic, Wegovy, and Other Weight Loss Drugs Improve Your Health, written by Kathy Casada on 3/19/24.
All righty.
I think that's 25, and was fact-checked, even had the fact-checker's name there.
And which periodical was this in?
This is Healthline.
Okay, Health
online. I'm impressed with it. So, but we talk about these drugs being primarily developed for glucose control, and now they're used primarily as a weight loss medication.
And that initially was like a follow-along benefit. The weight loss thing is just something that happens.
And a lot of the things that they do, for example, Wegovy was FDA approved for sleep apnea, treatment of sleep apnea.
Okay.
Well, the way it does it is causes people to lose weight.
Okay. All right.
There's no fat deposits in the back of their throat, so their throat doesn't narrow while they're sleeping, so they don't stop breathing and they don't snore. But it does other things that nobody saw coming, which I thought was worth commenting on. So decreasing risk of cardiovascular disease and stroke, it was also FDA approved to specifically decrease risk of cardiovascular death. And so what I've seen in my patients is ejection fraction, which is a number that is evaluated by an echocardiogram that tells us the effectiveness of the heart's ability to be a good pump. Okay. So I've seen ejection fractions actually go up.
Oh, wow.
In people who are not losing very much weight.
Wow, okay.
So I think the FDA approved it on the weight loss thing, but I think it actually does other things that they haven't really sorted out yet. So that might be one of the surprise. Decreased risk of heart attack, which in our language is MI, myocardial infarction, and cerebral vascular accident, which is a stroke. And in my opinion, this could also help people with cardiac arrhythmias, so things like AFib, hypertension, right? Your blood pressure goes down if you lose weight. And congestive heart failure, also better managed in people who weigh less.
But again, some of these benefits don't seem to be connected.
It seems to make the heart beat better.
Regardless of whether or not you lose weight.
And become a more effective pump. And I saw somebody with an ejection fraction of 20 who bopped up there the 40, which is way more consistent with being alive.
Is that something you'd feel?
Yeah.
Yeah.
I think you feel a well-being. You feel less problems with moving around.
Okay.
Probably less chest pain, definitely less what we call dyspnea on exertion, which just means losing your breath when you move around.
Okay.
So, and definitely less swelling.
Wow.
In ankles and stuff.
Oh, that makes sense. Sure.
Yeah.
You're just moving fluids more, right?
Yes.
Yeah.
So, the next one is chronic renal disease. So diabetes is the cause of a lot of kidney damage and a lot of people on dialysis and who need kidney transplants. It's a result of poorly controlled diabetes. So you kind of can intuit that improving glycemic control or how your sugars are when you're diabetic can improve kidney function. Okay, because higher sugars damage all those little fragile tubules and it makes the kidney not as good a filter.
So this is something that I've started visualizing just to understand better what the kidneys do. Essentially, what the lungs do with air, the kidneys do with liquid, with fluid, with blood.
Yeah, that's pretty,
the exchange.
That's super generalized, but yeah, I get your drift. Yeah.
So they are as much there's a barrier that's being passed when the kidneys are in proper operation.
Right, kidneys it's osmotic, and I think in lungs it's probably like oxygen pressure or something. But yeah, you get these tiny little structures that are really, really fragile that don't do well when there's too much sugar around.
Right, exactly.
So
wow.
So in people with type 2 diabetes, studies show that decreased risk of developing kidney problems is like 24%.
Like you're a quarter less likely to develop kidney problems with type 2 diabetes?
Right. And
wow.
Part of that is controlling diabetes. And again, I think part of that is something we don't really understand.
Right. It's like strengthening something on the other side too.
But this is huge.
Yeah.
You know, weight loss drugs in general only get approved. We said this before on the air, but only get approved if there's like a 6% reduction in weight, which is like nothing.
Yeah,
although a lot if you're really trying to do it.
If it's your 6%.
Right.
And even just statistically, medically, there's something like 24, expressing at a rate of 24%. That is huge.
That is huge.
Wow.
And currently we do have ways of decreasing diabetes effect on the kidneys by using a certain category of blood pressure medicines, but a lot of people can't take those because they're associated with really terrifying allergic reactions.
Ooh, okay.
Yeah. And they don't work at the level of 24%. They're like less than 10, I would imagine, if I had to guess. And so this seems like it could be much better protection, although this also brings up the question is, could this protection be additive? Probably not completely.
Additive on top of what?
If you put somebody on an ACE inhibitor and you had somebody on an Ozempic-like drug, does that mean you're going to get more than 24%? Or does that mean it just...
That's your top and
out. Yeah, that's your ceiling and you're not going above it. This surprised me. Decreased risk of colorectal cancer. Really good studies showing 25% decreased risk in people with type 2 diabetes, and they compared these people. They had I think a 1.2 million number of patients, and part of them were on metformin alone, and part of them were using metformin and then GLP-1 medications to control their diabetes.
Okay.
So two things I, as a provider, kind of draw from that. One is you can take metformin and have a GLP-1 and not have your sugars drop too low. That's people's always concerned because that's what happens with insulin is you can drop your sugars too low. But these drugs don't seem to do that. And the other one is that still a 25% decreased risk is incredible. And I think that's... So people with type 2 diabetes have a higher risk of colorectal cancer anyway. But it just seems like there's a mechanism that could be kind of extrapolated into the non-diabetic population.
Wow.
That's kind of what I'm picking up with that. The other thing is anything that causes a reduction in colonoscopy has to be a good thing. It's a little invasive, right?
Yeah. Someone I love dearly just recently had a colonoscopy, and man, that took days out of her life. That's just that's such a hassle.
I've been there, done that.
Yeah.
And it is, I mean, you're stuck in the bathroom for a lot of time.
Yeah.
And then after you have the procedure, it's kind of a fart fest, which is
I think
women don't admit to farting. So
the
it was
fasting was a very big.
The fasting was a big deal too. Although I kind of like fasting.
Oh, really?
But,
no.
Yeah.
All right.
Yeah. But I thought it was interesting because although I got Revised and don't really remember it, I at the time in real life was dedicated to really remembering the experience
really?
from
Seriously?
terms of medical intellectual curiosity.
Sure.
And of course I didn't. But that's a huge big deal too. And then also there's trials looking at specifically lowering risk of Alzheimer's and other types of dementia.
Wow.
And this is a problem I've had with my personal journey with diabetes, but I never really thought that patients paid much attention to it. But when my sugars are high, and remember for me that's like 126, so normal is 60 to 100. So even a smidgen high, I find it hard to concentrate on things, and I feel like I kind of got a brain fog going. But the assumption is that with lowering your sugars that you can think better, but also losing the weight. See, there's multiple mechanisms again at play.
And it seems there's one thing that we skipped over here in your notes, and I want to jump back to it because it just adds another facet to this. Substance use.
Oh, okay.
Anecdotally, it says you've written anecdotally information suggests that this category.
Yeah, that was a big important one, but I skipped it. I skipped it for reasons.
Oh, I'm sorry. Okay. Were we coming back to it?
It's not my sugar making me yes.
Okay.
And the reason I wanted to kind of leave that last is because that's specific not with diabetes. All these are related to what they've observed in people with diabetes using these meds.
And that was a question I had about whether or not, if it does all. So these effects could apply to general population. It's just not understood yet.
Yeah.
Yeah.
Because what they're seeing is a decrease in waist circumference is kind of what they think has something to do with people lowering their risk of Alzheimer's or other dementia.
Okay.
So it's not so much just that their sugars are down, it's more the weight loss part.
Wow. Okay.
Yeah.
Okay. Huh.
Yeah. So lots of room to ask questions and then move in a million different directions, I would think.
Yeah.
So with the substance use, and this is anecdotal information, so no real testing yet, but it suggests this category of drugs can decrease cravings for alcohol and nicotine. Wow. And so studies in process, but it seems to act on the brain in the dopamine-mediated pathways. Dopamine is kind of the high we're all looking for. Yeah, it's kind of activating. It's kind of intellectually engaging. It's kind of making you think that you can move in 1,000 different ways with very clear-minded.
Right.
And it's probably not necessarily what happens when somebody takes methamphetamine. But I'm wondering if this could be, because I've heard hallway conversations, could this be an actual way to help people get off meth? There's a lot of meds to help people get off alcohol, and there are medications that help people get off nicotine, but we haven't been able to do much. And then heroin, there's ways of dealing with that.
Ones,
but meth is kind of, there's not much you can do except send people to 12-step meetings, which I think is very powerful, not dissing it. But I think if somebody wanted to maximize their resources, this might be a direction to look.
Wow. Okay.
Yeah.
Okay.
So super exciting. It's also been FDA approved with sleep apnea, which is, again, related probably to the weight loss issue. I am starting to see providers on this drug for other reasons than diabetes.
How do you mean?
So I'm starting, we all take care of each other, right? And I'm starting to see people who are talking about microdosing this class of medication, principally Wegovy, because that's the most accessible. But for reasons that have nothing to do with anything we've talked about. And I think possibly might be like vague things like hormone balancing or, energy, clear pathways to thought and longevity.
Wow.
A lot of doctors are interested in longevity. So they do things kind of on the side that are not FDA approved, that are not particularly scary, but just weird.
That's interesting. Like just kind of like using yourself as a guinea pig or I mean, not so much as trying something out. I suppose you're not testing something, but you're trying to get a benefit from something, and this is
definitely
it's off
not
menu.
Scientific. They're going with some anecdotal feeling,
right?
And their understanding of how the drug works, what their problem is, and what pathways might be involved. So they put it together in their mind, but it's definitely biased. It's not research. It's not science.
Sure, but the anecdotal framework is going to be heightened somewhat because the people you're talking to and the people you're passing by in the hallway are other physicians.
Yeah,
other
I went
doctors.
to this conference, or I'm listening to this podcast, or my friend who's an internist says we should watch out for this because this seems to be something that could hypothetically work. And so I would say that most physicians are super skeptical about new drugs. They've been burned by them, like I was burned in the fen-phen thing. My first discussion on Ozempic on this show was pretty negative. But, we wait and watch. Well, they're starting to have positive feelings about it, which I think is super interesting.
I'm still curious about the things the doctors do on the side to themselves that are off menu things. Because I remember talking about with COVID, zinc. And you were talking how a lot of healthcare people kind of dose themselves with zinc prophylactically.
Right, and forced bathing. There was a big embracing of forced bathing.
Oh, yeah, but that's...
Oh, no, these guys were in it for disease prevention.
Really? What? Because I'm going, I'd just be using it as an excuse to get out. Okay.
No. So when they're citing the studies, in this case, it was Japanese studies from about 30 years ago. Obscure, it was like a trivia fest because we didn't have anything else and we were frontline and we were scared.
Right.
So, that's, I think, super interesting. And then remember that improvements, and if you're taking these drugs for weight loss, improvements in diet and increase in exercise, 150 minutes a week is minimum, especially weight training now, super important.
That's become a thing, right? Yeah.
My experience with the 40 or so patients I have on these drugs is if they don't exercise, nothing happens. And they come in and they talk about the cupcake, especially women talk about the cupcake they had at their kid's birthday party 2 weeks ago with great shame. And they can let go of that. If they just follow a generalized Mediterranean diet, I'm going to call that good for now.
Yeah.
And then, but exercise is it. You have to get up and move. And most patients virtually aren't doing that until all of a sudden, like something hits them and they get it.
Which kind of patients are we talking about? The people on Ozempic?
Yeah.
So if you are on Ozempic and you're not exercising, you're not elevating your calorie burn, they don't do anything?
Some people they don't.
I'll be darned. Okay.
Yeah.
Okay.
Some people they still can get away with it, but some people, if you're not moving,
you got it. Yeah.
Don't tell me that it's not working for you.
Yeah.
What's not working for you is you. So here's what I do when I'm trying to get a person on these drugs because they're super expensive and insurance companies, once again, make financial decisions, not ethical, moral, or medical decisions. In fact, they block those kind of decisions. So what I do is I call the patient in for an appointment. It's not an over-the-phone appointment because it needs like vital signs and needs lab work done. I kind of do a wide net of labs. I try and find every little suggestion that they might have one of these problems. And I highlight it in a like epic tome with a note with 1 million diagnoses, all kind of catered to tell the insurance companies, like, this is going to be bad unless you intervene now.
Oh, wow.
And it makes the patients really sad because, it's really kind of over the top. It's not dishonest, but it's it's one big place where I can highlight all this potential that doesn't sound so good.
Right, right.
And then,
so is it off-putting for the patient? Like, oh my God, it's scary?
I didn't know I was that sick.
Yeah. Well, for insurance purposes.
This is a good thing right at this moment in time. Embrace it. And then, so at UHS, super lucky, and probably this works at Open Door too, to have an in-house pharmacy where you can actually talk to the pharmacist and talk to the techs. And the people doing the prior authorizations are really motivated for good health for the patients of their particular organizations.
Really?
Yeah.
That's
So
good.
I almost always send these prescriptions not to commercial pharmacies because they're overburdened and this takes more energy than the average farm tech can put into it. And then usually get turned down and then I listen to the reasons why it's turned down. The usual reason is one of two things. They haven't demonstrated they've done a diet and exercise program. And so I have to re-highlight that in the second visits note. And then the other thing is our organization doesn't cover drugs for weight loss, which I'm not really asking for it for weight loss. Usually
that's
I bury that.
And that's tricky because that's the mechanism by which this person is going to benefit.
Most of the time, but
not the
100%
goal.
of the time. Yeah.
But is it the goal? No, it's not the goal.
Well, it depends who's asking me that.
Well, yeah, right, yeah,
So,
exactly.
So I'm highlighting prediabetes and hypertension and family history. There's also some thought that weight-related cancers, like breast cancer in women, is a big deal. Family history of breast cancer, and I'm, maybe sleep apnea, and if it has been diagnosed, I'll do the studies, but also call it a sleep disorder. It's got like 5 or 6 different diagnoses, and then the last one is, by the way, they're morbidly obese. If you didn't see that coming,
right.
So the second visit, oftentimes you have the first visit, the first attempt to get the drug turned down. So for most people outside of partnership, which is way more enlightened and more likely to say this is okay.
Wow.
Then you come in for a second visit. I answer all the things that they brought up as reasons why they turned it down.
Kind of revising the
I argue
request.
back. Spit out another epic tome. And then the second time, oftentimes you have, I think, a 75% chance of getting them to say yes, even if they're private insurance. So just because you've been turned down once by your doctor's attempt to get you these drugs does not mean that you should stop trying. Okay? And as more of this stuff comes out, your provider should be noting if it applies to you and making a comment like, gee whiz, this would be great if we could use these meds. And oftentimes they say yes, and a lot of people do really great on them.
How's that work? What do you mean? Like, where is it? Where is the? Where are you able to write? Gee whiz, it would be great if we could use these meds.
Well, that's what it is in the vernacular. But I'm writing this like, risk would be reduced. Risk would be reduced. Risk would be reduced.
Okay, gotcha. I see.
Yeah.
As part of the request, then you're justifying.
So I'm not just doing this for weight control. I'm doing this for
right.
6 other reasons.
Wow. Does it seem like you're hitting like the keywords, the magic phrase, say the magic phrase, and the duck drops from the ceiling kind of thing?
Yeah, I learned 2 things from this. Yeah, it's definitely highlight all the comorbidities you can highlight.
Right.
But the second is keep trying to get it. Because they tell you no once doesn't mean they're going to tell you no the second time.
And you don't time out, right? After 5 requests, they go, I'm not going to answer this again. You can keep asking until you get it.
No, you can keep answering. Okay. And then what's happening is there's data coming in. And if the provider is paying attention, to that, they can say, "Oh yeah, and this is new, and the FDA just," and
Are you able to do that, to sort of cite research and requests or justifications
I have,
like this?
and in peer-mediated conversations, I said, "Look, I cited all this research," and she goes, "Oh, I never even read the notes," and I'm like, "You're not my peer, then."
Yeah.
Yeah.
Nice.
So,
yeah, that's good. That's good.
yeah.
Wow.
So what I'm saying is perseverance. So what got that woman what she needed was being on hold for 40 minutes.
Wow.
And I wasn't really. I had a medical assistant on hold. So we have minions too. You know?
Good, because your time is like pretty expensive. That's like, that's not something you want to spend your time doing.
Well, it's also pointless. It's designed to get you to hang up.
Right. Oh my God.
So
how much does Ozempic and these drugs? How much do they cost these days?
Oh, it can be like $1,000 a month is the copay.
The copay?
Yeah, 14 to 17,000 probably.
Jesus.
Sorry, not 1,000, 100. 14 to 1,700 copay can be 800 to 1,000.
That sounds like a most pay, but yeah, okay, all right.
Yeah.
Wow.
So just work with your provider, and this means you have to come in, and people try and do it over the phone, but that's not as effective a visit because, a phone visit in my world is about 10 minutes usually.
Yeah.
And I don't know how to explain it. There's no vitals associated with it. It's not really quality medicine in any way. It's just like using me as like a gumball dispenser or something.
Right.
So that doesn't get you anywhere. You really have to come in and demonstrate you're committed to this. Most people do well on it, but most people do better on smaller doses, which makes me think that's why the microdosing interest is happening. Okay. But if you use the words microdosing,
it kind of gets
then they're like,
hold up, hippie.
Yeah, go away. We're not going to listen to this. So you just have to persist.
And I'm sorry, what are the healthcare people, the physicians, the other folks, your peers, what are they using it for again?
Longevity mostly.
Longevity.
And so that's a big ball of wax there.
Yeah.
There's a lot of things. I think if I really investigated it, I think my profession is all terrified of losing their marbles.
Oh, sure.
Their intellectual ability is really important to them, and they have honed it, and it has done well for them in their lives. And the thought of being at a sniff somewhere is like their worst case scenario.
Right. That makes perfect sense.
Yeah.
Wow.
So I think that's part of it. And the other part is that they have some vague ideas about balancing their hormones and stuff, and it's a little hard for me to understand. But
like across the board, this is kind of a typical sort of thing?
Yeah, it's a data-free zone.
Sure.
I think, which makes it hard to...
Which is kind of an idea of everything being in balance, sort of?
Yeah, some vague idea about their hormones. But,
specifically hormones?
Well, remember, when we say hormones, we're not talking about testosterone and estrogen. We're virtually everything that happens in the body is hormonally driven.
Right.
There are probably hundreds of thousands, maybe even millions of hormones.
Wow. Okay.
So, so it's a little unclear.
Wow. All right. That's really interesting. I wish I could be a fly on the wall and hear some of those conversations.
I know they're very strange because I've written scripts sometimes for people like off the record that are not at all street value scripts, but like there was a big interest in metformin because it could reduce your cancer risk and save your pancreas. And I don't know, a lot of doctors drink alcohol. Maybe that's their interest in pancreas. I don't know.
That's me.
I don't know. But they were a fun bunch at meetings, let me tell you.
Well, Lynn, thanks for coming back and revisiting a topic that needed to be revisited and sort of revised in the Health Matter records. That's great. That's cool. All right. Well, we'll see you next week.